Hi doc, what's wrong with me? Last week I could whip the world. Now I'm so stiff and sore I can hardly get out of bed. I feel like I've aged 40 years overnight. Welcome to my discussion about polymyalgia rheumatica. This is different than the other talks that I have given in rheumatology, in that this lecture was never given to sophomore medical students. Be sure to click Introduction to Rheumatology listed below to see the other talks that I have given.
So what is polymyalgia rheumatica? Basically, it's an inflammatory disease of an older adult where there's a sudden onset of pain and stiffness in the shoulders and hips. There's an elevation of the acute phase reactants, and there's exquisite sensitivity to therapy with corticosteroids. What causes it? Why do we get it? There does seem to be a genetic basis in that there is an increased incidence of certain HLA-DR4 alleles in patients with polymyalgia rheumatica. There are also certain polymorphisms of HLA-DRB1. This would imply the genetics of the immune system can at least put one at risk for this. And as with many of the autoimmune diseases we treat, there does seem to be something in the environment that may kick it off. The data that supports this is that there is evidence of seasonal variation. Now, it is an autoimmune inflammatory process. There's data to support that. There's an increase in the T helper cells Th17, and the regulatory T cells are decreased. Also, the pro-inflammatory cytokine IL-6 is elevated. Now, even though it's called polymyalgia, it is not a muscle disease. Primarily, it affects the proximal articular and periarticular structures of the joints, in particular bursa and tendon. Some have called it a polybursitis. In this picture are the slides from Salvarini and Muratori and up to date. One can see the increased uptake in the bursa of the shoulder and the bursa of the hips. Again, a polybursitis. Patients typically report the sudden onset of pain and stiffness in their shoulders and hips with profound morning stiffness. History taking is really a key in evaluating this condition. So when I'm taking the history, I'm very carefully listening for changes in function. I call it looking for corners. In other words, they're getting along okay, going in this direction, and all of a sudden they're turning the corner and going in that direction. Another way I sometimes consider this is the patient may go to bed a young man and wake up an old man, or a young woman wake up an old woman. There's really a sudden change of function. With respect to functional loss, this needs to be queried about, asked about, and it needs to be watched for. Are there problems putting on the coat? Is there problems getting out of a chair, fastening a bra, externally rotating the hips in order to put on socks? And I demonstrated that when we talked about osteoarthritis. The patients have profound stiffness, and this can last several hours when they get up in the morning. They also get gelling with sitting. Constitutional manifestations can occur, and this can occur things like fatigue, loss of appetite, weight loss, perhaps low-grade fevers. If one's evaluating and thinking of polymyalgia rheumatica and they're having high-grade fevers, other diagnoses need to be watched for or considered, especially things such as giant cell arteritis, which can be associated with polymyalgia rheumatica, and we'll discuss that in a minute. I think that the epidemiology is important in evaluating this. This never occurs in people less than 50 years old, and most commonly occurs in people in the age between 70 and 80. Women are affected more often than men, a ratio about 2 to 3 to 1. It seems to affect people of Northern European descent more often, although this isn't all that helpful in the office when taking a history, because I've seen it occur in people of other ethnic and racial groups. The lifetime risk is about 2.4% in women, about 1.7% in men. So this is a fairly common condition, even though a lot of people have not heard of it. When I go to do the physical examination, that actually begins the minute I walk into the room or the patient walks into the room. I'm watching for loss of function. Are they having trouble taking off their clothes? There is tenderness with range of motion of the shoulders and hips, and there can be loss of motion, and that's demonstrated in this picture. The gentleman on the left cannot lift his shoulders above 90 degrees until he's treated, and this is before and after treatment. Typically there's not a lot of palpable synovitis, and which is different than rheumatoid arthritis, where there's actually a lot of swelling of the joints one can feel. This is usually not felt unless they have the associated condition remitting seronegative symmetric synovitis with pitting edema or RS3P, and I'll talk about that in a minute. And again, in doing the physical examination and the history, it's important to think about and ask about giant cell arteritis. There are a couple of associated conditions that can occur with polymyalgia rheumatica. Perhaps the most worrisome is giant cell arteritis. This is a condition of inflammation of large blood vessels of the head, neck, and upper extremities, and can occur in 5 to 30% of patients. It is a concern because it can lead to blindness. There can also be strokes and other symptoms. So patients that present with polymyalgia rheumatica need to be queried or asked about headaches, visual changes, or pain with chewing, jaw claudication. If they do have any of these symptoms associated with polymyalgia rheumatica, high doses of corticosteroids need to be initiated, and they need to be referred immediately to rheumatology and to a surgeon for biopsy and or get imaging to see if one can find this. I hope to give a lecture on this at a later time. Another condition that sometimes can present very similarly to polymyalgia rheumatica, only more often with swelling of the hands and pitting edema, and that's a condition called remitting seronegative symmetric synovitis with pitting edema, or RS3PE. And again, these patients have remarkable swelling of the hands. There's a lot of synovitis of the extensor tendons of the hands. And these patients are very sensitive to therapy with corticosteroids, like patients with polymyalgia rheumatica. So what special studies are done to aid us in evaluating this condition? Firstly, the acute phase reactants, erythrocyte sedimentation rate or Westergren sedimentation rate, and the C-reactive protein. These are almost always elevated, but again, not 100% of the time. So they're very helpful, but sometimes this diagnosis needs to be considered when they're not elevated. I check a complete blood count or CBC, looking for clues of hematologic disease such as leukemias, etc. The chemistry such as glucose, creatinine, liver function tests, and calcium are checked, looking for other underlying diseases. Thyroid test, TSH, thyroid stimulating hormone, is checked, again looking for clues of hypothyroidism. CPK for evidence of muscle disease and vitamin D. Rheumatoid factor and cyclic citrullinate peptide are checked to see if there are any clues of rheumatoid arthritis, although I will state that if I do not find any clues, specifically peripheral synovitis, on examination, if they have the rheumatoid factor in the CCP and it looks like polymyalgia rheumatica, I will still treat as polymyalgia rheumatica, however continually evaluating for clues of rheumatoid. And then in patients that have a very high SED rate and are not responding to therapy, or the SED rate's not dropping with therapy, I will also check a serum protein electrophoresis and urine immunoelectrophoresis, looking for clues of a paraprotein such as occurs in multiple myeloma. The paraproteins can cause an elevation of the sedimentation rate. Generally, I do not do imaging. However, when we talk about the classification criteria that's used by the EULAR and American College of Rheumatology, one will see that there is a classification criteria that does use ultrasound. Now, how do I diagnose this? This is considered in an older person that has the sudden onset of hip and shoulder pain, especially if there's loss of function. And we do look for the acute phase reactants, the elevated SED rate, the elevated C-reactive protein. So if they have acute loss of function, hip and shoulder pain, and elevated acute phase reactants, this is strongly considered. However, again, it's very important to rule out the other conditions, and we're going to talk about those in a minute. If I'm pretty certain this is what's going on, then I'll initiate a trial of very low dose corticosteroid, specifically prednisone 5 milligrams twice a day or 10 milligrams a day. Prednisone, however, is a prodrug. It has to be metabolized by the liver to its active metabolite, and sometimes when patients don't respond to that, I will then change to methylprednisolone 4 milligrams twice a day or dexamethasone 0.75 milligrams twice a day to see if I can get a response. Again, if I'm not getting a response, I am continually looking for other potential diagnoses. If that doesn't work, I will then again reconsider my differential diagnosis and work the dose up to about 20 milligrams of prednisone a day. Now, if one looks at the guidelines of the American College of Rheumatology and EULAR, they actually suggest going up to 25 milligrams of prednisone per day, and actually maybe even starting at that dose. The problem with prednisone is anything will respond to prednisone if given a high enough dose, and I'm talking about cancer, infections, etc. So I prefer starting with a very low dose because I know typically polymyalgia rheumatica responds to that, and it helps me in my classification or diagnosis. So that's how I diagnose it. High SED rate, shoulder and hip pain, older person, exquisite response to corticosteroids. Now, the European League Against Rheumatism, the American College of Rheumatology in 2012 came up with a classification scheme. This is for classification for studies, again, as we discussed in some of the other conditions we treat, and not really a diagnostic classification criteria. Note again that they apply this to patients that are greater than 50 years old that have bilateral shoulder pain and have elevated acute phase reactants, SED rate, and C-reactive protein. There's actually two criteria schedules. One is for patients that do not have an ultrasound. In order to classify, they require that they have 4 points on the scale. Or in patients that do have an ultrasound, they require 5 points. And one of those points, of course, if you do an ultrasound, they're looking for clues of a bursitis or tendinitis on ultrasound. So this scale, when used, or this classification criteria when used, is not particularly sensitive or specific. It's only about 68% sensitive and 78% specific if no ultrasound is done, and down here you can see 66% sensitive and 81% specific. So this again is helpful for studies. I don't use it for diagnosis. I want to spend a little bit of time talking about the differential diagnosis of polymyalgia rheumatica. I do this primarily because really there's no pathognomonic findings or tests for the condition. As we discussed, stiffness and pain in a response to corticosteroid. And so I think it is really important to consider the differential. Number one, multifocal local musculoskeletal disease. Tendinitis is common in the people as they get older. It's just sort of a cumulative trauma to the shoulder can put one at risk. Likewise, osteoarthritis of the hips, and so these patients can present with hip and shoulder pain. In our picture here we see really severe osteoarthritis of this left hip, and in this we see that the humerus is riding high in the glenoid, suggesting rotator cuff insufficiency. Typically, however, this type of pain in the shoulders and hip is more insidious in onset. It's generally not associated with an elevation of the acute phase reactants, erythrocyte sedimentation rate, and C-reactive protein. They may have some response to corticosteroid, but it is not as remarkable as one sees in polymyalgia rheumatica. There are not constitutional manifestations such as weight loss or loss of appetite or morning stiffness. With respect to evaluation, imaging can help. One can get an x-ray of the pelvis and see osteoarthritis of the hip. One of the problems, though, with this is that, again, given that these types of conditions are common in the elderly, they can occur with polymyalgia rheumatica. Bone disease. Multiple myeloma has paraproteins and can be associated with a very high erythrocyte sedimentation rate. The patients obviously feel crummy because they have bone cancer, and they can have a lot of pain in their bones. They typically don't respond well, although can respond partially to corticosteroid therapy. And I consider this, especially if the sedimentation rate is not dropping or they're not responding to therapy as I think they should, then I'll check a serum protein electrophoresis and a urine immunoelectrophoresis looking for clues of the paraprotein. Hyperparathyroidism can be associated with a lot of bone pain, and the clue to this would be an elevated calcium on the blood work. Hypothyroidism, this can cause an elevation of the sed rate and the C-reactive protein. The patients can be very uncomfortable and have a lot of difficulty initiating activity or movement. The statin drugs, which are used to treat elevated cholesterol, sometimes can be associated with the onset of myalgias, that is muscle pain in the shoulders, hips, etc. We talked at length about fibromyalgia, and you probably recognize this diagram of the classic fibromyalgia tender points. They do have a widespread aching. However, again, the onset is much younger, typically more insidious. In other words, they can't necessarily point to a time of initiation. It's not associated with elevation of the sed rate or the C-reactive protein. They may have a partial response to corticosteroids. So again, corticosteroid is not your only diagnostic criterion making this diagnosis. And again, this needs to be considered when initiating a diagnostic challenge. Infections such as endocarditis can be associated with a high sed rate. They will sometimes have heart murmurs and fevers. This is just an example of splinter hemorrhages, which can sometimes occur with endocarditis, which is an infection of the heart valve of the heart. Septic arthritis, this is just fluid from a septic joint, which is very cloudy or purulent, that you'll recognize if you watched my talk on synovial fluid evaluation. I did have a patient many years ago. He was actually a physician. He presented with shoulder pain primarily. He was on low doses of corticosteroids. However, when he did not respond, he took it upon himself to boost the corticosteroids and boost the corticosteroids. And each time he boosted them, he did feel like he had a partial response. But finally, when he did get in to see me, we found that he had a septic arthritis of the sternoclavicular joint. This sort of brings up the old adage that a physician that treats himself has a fool for a patient and a fool for a physician. It's very important if you are a doctor to see another doctor if you get sick. Early Lyme disease can sometimes present with pain and stiffness and just sort of a crummy feeling. Other autoimmune diseases, rheumatoid arthritis can present like polymyalgia rheumatica. The rheumatoid factor and the cyclic citrullonated peptide can be helpful. But if it just looks like polymyalgia rheumatica, even if they do have a rheumatoid factor or a CCP, I will treat presumptively as polymyalgia rheumatica, but watch them carefully. I would also follow x-rays for any clues of erosions in those patients. There is an overlap between polymyalgia rheumatica and seronegative rheumatoid arthritis in the elderly. Again, it is important to follow these patients carefully. In one study, 20% of patients with polymyalgia rheumatica eventually had their diagnosis changed to rheumatoid arthritis. Inflammatory myopathies, these patients a lot of times will have weakness of the shoulders and hips and loss of function, inability to raise their arms, or inability to stand up. Pain is not as much of an option. They can have an elevation of the sed rate and the C-reactive protein. It is important to look for clues such as elevation of the muscle enzymes such as CPK, AST, etc. Spondyloarthropathies, we've talked about those before. This is the gentleman with the ankylosing spondylitis. And these patients do have a lot of axial involvement, shoulder and hip involvement, although again, this tends to occur at a much younger age than the patients that we have with polymyalgia rheumatica. Parkinson's disease patients have a lot of stiffness, although pain is not as much of an issue. The sed rate and the C-reactive protein are typically normal. Loss of function is an issue. It's important to look for cogwheel rigidity in these patients. Calcium pyrophosphate deposition disease. These patients, we talked about this, but they can get calcium deposits on the cartilage. You see that here, or this is what we call a crown dens, where there's calcium deposited above the periodontoid area of the neck. Certainly they can get acute flares in these areas. When they occur, there's marked pain and stiffness, elevation of acute phase reactants, and they do respond very nicely to corticosteroids. However, long-term treatment is better with nonsteroidals, anti-inflammatory drugs, or colchicine. An X-ray of the shoulders and CT of the neck can help in the diagnoses. Vasculitis other than giant cell arteritis, the patients can present just feeling crummy with arthralgias and elevated acute phase reactants. It's important particularly to check for these if there's pulmonary, renal, or neurologic involvement. Sometimes the anti-neutrophil cytoplasmic antibodies, or ANCAs, can be checked, looking for clues. Then lastly, I listed malignancy. Typically we don't see a lot of problems with muscle and joint pain with cancer. However, some of the myelodysplastic symptoms can be associated with rheumatologic symptoms, and thus it's important to check a complete blood count, or CBC. And then lastly, some of the medicines that are used to treat cancer now, in particular the checkpoint inhibitors such as ipilimumab or Yervoy, can be associated with musculoskeletal pain and sometimes flare of an autoimmune disease. With respect to treatment, I alluded to how I initiate treatment when we were talking about diagnosis. Specifically, I start with prednisone 5 milligrams twice a day. If I get a very gratifying response, as I would expect with polymyalgia rheumatica, the taper will be 1 milligram per month down to about 5 milligrams per day. And then usually at that point I'll slow down a bit and start tapering at 1 milligram every 2 months. And eventually we'll get the patient off of prednisone altogether within about 15 months or so. This is a total cumulative dose of about 2,100 milligrams. Now, the EULAR recommendations and the ACR recommendations are starting in a dose of about 12.5 to 25 milligrams per day. And in the article on Up to Date by Salvarani and Muratori, they suggest starting at 15 milligrams a day. So you can see I tend to use a much lower dose, but again, that is because I want to make sure that a lot of things that can look like polymyalgia rheumatica generally don't respond to that low of a dose. If there's not a good response to the prednisone, then I will try either methylprednisolone in a dose 4 milligrams twice a day, or dexamethasone in a dose of 0.75 milligrams twice a day, again, since prednisone is a prodrug. If during the course of the taper I get a setback, in other words, the patient goes back a bit, usually I will increase the dose 1 to 2 milligrams and then start the taper again. Now, most of the time with polymyalgia rheumatica, they'll respond to that. Again, if I'm not getting the response I expect, I will reevaluate my differential diagnosis. If I don't get a good response with the prednisone 10 milligrams a day, again, I will reconsider my differential diagnosis, and the prednisone will be worked up to 20 milligrams per day. If during taper there are problems and I can't seem to keep working them down, then I will consider the addition of methotrexate, or more recently there's been a nice paper supporting the use of the IL-6 receptor antagonists, seralutinib or Kevzara, and this is actually approved by the FDA for the treatment of polymyalgia rheumatica, and there's really not a lot of medicines that are approved by the FDA. The problem with the newer biologic therapies is their cost. Prednisone for a 1 month supply at 5 milligrams twice a day is only $4.20 a month. Methotrexate at the usual dose of about 15 milligrams a week. They're 2.5 milligram tabs, so that'd be 6 tabs a week, is about $11.36. But if for seralutinib, 2 shots a month is about $5,554 per month. And I have referenced where I got this data in my bibliography, which is actually will be attached, and if you look down below you'll see that I've attached where you can look up that bibliography. With respect to treatment, it is important to continue to reevaluate. I continually watch for other diseases in the differential diagnoses. I continually watch for giant cell arteritis. And since we are using prednisone, it is important to monitor for osteoporosis. The prognosis for polymyalgia rheumatica treated is very good. Most of the time I'm able to get a complete response to therapy. Most of the time I'm able to get the patients off of prednisone. Generally just by tapering the prednisone, although occasionally I do have to add things such as methotrexate. I must admit I've not used a biologic to treat this yet, even though, like I say, seralutinib or Kefzara is approved. Now, I don't know what the prognosis is without treatment, and I really could only find one article describing this. This is by a gentleman named Brouwer, and he published this in an open access journal by Dove Press. Again, I've referenced that on my bibliography, but I don't know how well that article was refereed. But what he saw in 62 patients with polymyalgia rheumatica that were not treated with prednisone, however, he did use nonsteroidal anti-inflammatory drugs, and he did use hydroxychloroquine or Plaquenil. If there was no giant cell arteritis, most of his patients, about 84%, evolved into a seronegative rheumatoid arthritis. This was generally responsive to treatment with hydroxychloroquine. I've not seen the natural history of polymyalgia rheumatica in any other discussion or textbook, so this is interesting to know. Again, with respect to this article, I could not find any comments of the peer reviewer. So in conclusion, number one, it's important to consider polymyalgia rheumatica in any patient that reports a sudden onset of stiffness and pain and loss of function that is older. And typically, like I say, a lot of times patient will describe going to bed a young man, waking up an old man. Watch for corners, watch for changes in function, going forward or turning right. When one's evaluating for polymyalgia rheumatica, be careful to watch for giant cell arteritis. And again, ask about headaches, visual changes, jaw claudication. Those are present. Refer high doses of corticosteroids, get a biopsy. In treating polymyalgia rheumatica, use very low doses of corticosteroids. And by that, I typically use 10 milligrams of prednisone a day. However, we did talk about how the Euler ACR suggests going up to 25 milligrams a day. We did talk about the fact that prednisone is a prodrug and that there's other corticosteroid preparations that could be used, such as methylprednisolone 8 milligrams a day or dexamethasone 1.5 milligrams a day. And these are all equivalent to about prednisone 10 milligrams a day. Continually reconsider the differential diagnoses, in particular if the patient is not progressing as expected. And I always tell my patients I reserve the right to change my mind. This is probably true of any of our autoimmune diseases, or maybe most disease, that one needs to always be aware that there's other things that can look like what we're treating. And certainly we consider the differential diagnoses, but as disease evolves, it may become more obvious that something else is going on. This condition is very gratifying to treat for both the physician and the patients. And to the patients, it's almost magical. They come in hardly functioning. Within a couple of days, they're pretty much back to normal. I always said that this condition leads to at least 10 other consults, because the patients go home, they tell their friends, they tell their family, and all of a sudden I get a bunch of the friends and family coming in for an evaluation, hoping they have a similar condition, although a lot of times it's things like osteoarthritis or fibromyalgia, which doesn't respond quite as well to this treatment. That's the end of this discussion today. Thank you for listening.
Thank you for coming to my talk about polymyalgia rheumatica today. Please be certain to check out the other talks in Introduction to Rheumatology listed below.